There's a world of difference between what I get involved in with heart patients and what you can get involved in with stroke patients. And the reason is this, it's a very simple reason, that a person can have a heart attack, be admitted to hospital, let's say on a Monday, they decide they're going to do surgery on the Tuesday, they have open heart surgery on the Tuesday, the following Tuesday they're home. Now they may not be feeling all that well and they've got a stack of medication to take, but it's a sort of a one-off, and if provided they do the right thing, their life has been saved and they can go on almost with the normal things that they did before. Very different with a stroke patient, because that's if you like, a protracted thing, and that's the one that you some difficulty in dealing with, particularly in what sort of conversation you have. My name is, because I think you need to still tell them who you are, but you probably have already heard that there's this process going on. There's volunteers visiting people and so on, and so that they know about it. But I think it's still important to actually introduce yourself by name. Probably, I've got my sticker somewhere, it's on the bag, I think. I think you'd probably be wearing a name, yes. But at the same time, I think it's important to, and I noticed at the beginning, I think it's very important to address people, even if you do know their first name, in this context, you address them by Mr. or Mrs., right? And also, just to go back to the beginning, I always knock at the door, even though it's wide open. Because it often happens that you look around the corner then and they're not there, they're in the having a shower or something, right? And I just go away and come back. But I think it's important to almost sort of do it at a formal entry rather than just wandering in. And I think that's important for people. And that's giving them the dignity and the respect that I think is what they should have. And then, of course, if you know their name, but to address them by the name, right? And I think that's important. I'm given a notebook. I've got a notebook, and I write down the name of the room and the name of the person, and walk in and say, I'm Mr. Jones. I've come around to say hello to you and so on. Whatever I know by the name by that time, and rather than saying, I'm sorry, I don't know your name, which is not a very good start at all for people, right?
Our role is very...
Oh yeah, that's why we
slalom.
And really about listening. Yeah, really that listening and informal counselling kind of role. Just as we were speaking before, I'm thinking maybe if you were to say something like, I'm part of the stroke survivor visiting team, that's quite simple language.
Mm-hmm.
And then mentioned that, I understand the staff have spoken to you about having me come to see you today, and they will often then respond to that.
That sounds, so stroke surviving.
So I'm part of the stroke survivor visiting team, and I understand that the staff have spoken to you about having me come and see you. I know this may sound a bit ochre, but as I walk into the room, my name's Dave Robinson, I'm from Heart Support, and my only qualification is I've been there and done that.
Mm-hmm. That's a good one.
Now, been there and done that is a phrase that it's got into the language a bit, doesn't it? It's a bit ochreish, but then I perhaps explain a little bit more, if they ask, well, if somebody says, what does that mean? Well, I've had heart surgery or whatever it might be. But that, in a sense, that answers the question that you're not there as a medical specialist, you're not there as a psychologist or a social worker or anything else. You're only there because you've been down that road and you've managed to walk to the end of it, or not the end of it, but you've survived.
And I guess that could be phrased, my only qualification is that I too have survived a stroke.
Yeah. My only qualification is I've survived, yes. I think people would then, they'd know that you have experienced similar, not the same, but similar to what they've had.
That was exactly what I was thinking of. Last night I thought I'll go in, introduce myself give my name and then tell the person that I was here last year as a stroke patient and I have recovered, and I love to share my experience, how I recovered with you. You know, I thought, and then I thought that's my opening line, you know, to let the person know that I was a patient, I've been through this journey, and I'm here to share my experience with you. And then she'll be surprised and say, oh, you were here, when did it happen? Because I was thinking, you know, of myself like that. And last night, actually, I told my husband, you are the patient, I'm visiting you. So we did a bit of a role play. So he told me, you don't want to be so formal and say, I'm Marie Ten, because they're not interested, you know, you just give your name and then, you know, be very, very friendly in your approach, and then make yourself known, and then tell the person that you actually had stroke and you have survived, and then just let the person know that you are here to share your experience, and the person might start to ask you, and then you study the person and see what condition exactly she's in. Say, you know, if she's able to talk, and then she might open up and say, oh yeah, I've been here for how long and I've already got the information. So hopefully I've already got the information about her. And I was thinking that's how I can start, by being a friend, and she knows that I've been there, as you said, I've been there, I've done that, and how I recovered. And then I can be honest and say I still have my very bad days. There are days when I'm still very unbalanced, I feel very, very giddy, and how I go about it. So I thought, you know.
How do people react to that approach?
Well, instead of saying I come here to share my experience, we have to take care of their experience. We were sharing both experience.
Yes.
Because they have something, well, I'd be interested to hear about them, how it happened to them, or what they have been going through, and you start making links, you know.
Yeah. Because when I was in hospital, I kept wondering, what do I do from here on, you know? So, and then later I found out, oh, there will be all the support group. I'll be getting physiotherapy, and then home physio, home OT. So I thought, you know, maybe I can just, is it too bold?
Well, I would say
Person know?
let's not answer question because before they've been asked.
No, no, I'm anticipating what they will be asking me, because I was lying there and wondering what's next, you know, what's next for me, what's my future. I was very, very confused and a bit depressed. So, you know, it will be nice to tell me someone.
And I guess, Mari, it will be about drawing out their experience.
Yes.
So you're not going in to share your own.
Yes.
That experience that you have is going to help you listen to their experience, and maybe that, you know, that lived experience of having a stroke will help you to be able to kind of guide the conversation. Yeah, so it's really about I guess I can't emphasise that enough. It's about them speaking and as a visitor, like listening, and it probably will come out in the conversation that maybe they'll say, well, how did this happen for you? And you will then share a little part of that.
Yes.
Yeah.
I will remember to be a listener first of all. Then a
and
talker.
they will be curious about, you know, your process. Knowing what to expect in terms of the planning and things like that is different for everyone, and the team will manage that in terms of letting them know what to expect in terms of services.
Especially, I think they might have the complete different stroke than you had, and maybe the effects were different as well.
Different
so
parts.
they recover, but very different again. So that's why when they lead you, like ask you or tell me about you, then it's fine to talk about it, but maybe don't to start with that, like, oh, that's what I've done, because maybe it's not applicable to them at all.
That's why I've got this phrase here, the conversation, it could begin by asking the patient what their experience of stroke has been, or by waiting for to respond to your identifying introduction. I find that some people, if you identify yourself as having had a stroke, for example, or let me go back to my experience, you've had a heart attack, the person often says, what was it really like having open heart surgery, you know? Did you have trouble recovering? Did you have to spend time in ICU? All these sort of questions, and in a sense, it becomes almost coming directly from the patient, and then you might respond by answering the questions, but in a sense, they're in charge of what's happening.
Yes.
And that's the point I think I'm trying to make. And often, most people, my experience has been that most people are more than willing to ask the questions, because underneath it all, it's a great deal of anxiety, you know.
I agree with you there. There's a lot of anxiety because you've never been in that situation before, and it's scary, very scary.
One of the interesting things that I've learned is that if a person is anxious about something, if they can express their anxiety to you in whatever way they choose to do it, they are less anxious having done it than they were before they started. In other words, they're able to give a shape to their anxiety rather than just being a sort of a cloud sitting inside their head, you know. It's a bit like that with depression. I've had occasional bouts of depression, nothing very dramatic, but the moment I've been able to, not only to myself, but to acknowledge to someone else, that it seems to sort of evaporate a bit. Not entirely, but it evaporates.
I see what you're doing there sometimes to write it down as well. That gets it out of there and into there, doesn't it?
Yes, So to encourage the person to do at least 90% of the talking, you're ahead. And as long as you're making appropriate responses to keep the ball rolling a bit.
In my experience, I did little baby steps when I was getting better. Goals.
Yes.
So I didn't have goal that I was going to drive a car or whatever, go get out the hoist or anything like that. I just had little baby steps, like maybe I could pick that piece of paper up and put it where it belongs and things like that, you know. So I don't know what stage people will be at, but is it okay to give that kind of what I did, you know, when I'm talking to them, how I got over it?
Well, that may be very helpful in some cases. It may not be in others. And if you listen to what a person's saying and pick up the fact that one of their anxieties is the ability to do a simple thing, then you may reflect on that and say, yeah, well, I had that experience as well. And it took me quite a while to learn how to do that. Now, that's an appropriate response, right? But to tell them about that and not knowing whether or not that is an issue for them, it's just simply adding something on top of it.
And
That makes sense?
the patient sets goal with the physiotherapist. I've been setting goals like, well, I did big goals, like I want to play piano again, which was a big one.
I did big goals too. I wanted to walk and you do.
Yes,
in the back of your head, you think, I'm going to do that.
That depends, because making progress is
all achievement, isn't it?
yes, and you have to observe your body. You say, oh, last week I couldn't lift my little finger, I can. It's getting
That's
higher.
right. That's right.
Very simple things.
Doing little exercises and things like that, But
And
the
one of the
physios do
concern
that.
I have is about the memory, how the strokes affect the memory and the speech, because it takes in, like we asked Bruce yesterday, like we speak, we don't realize that the patient is exhausted because connection, like listening to a conversation. And one of the big thing after a stroke is to be able to communicate, to feel like communicating, because it's an effort. I just remember that when I came back home, I was not listening to conversation, I was not interested because I didn't think my participation would be interesting enough. I had nothing to do. nothing to say. It took time when I started making jokes, and so I said, "Oh, something happened. I feel good now." Things like that, you know. It's just a communication. We have to be very aware that it's very demanding. You just
Yeah,
don't. You just have enough of the situation, lying in a bed in the hospital, having a kind of conversation. So.
And that's why we have to keep the time not too long either of this participation. Yeah, we just have to make sure it's not over tiring for the
Yeah,
participants.
perhaps that should be put in the initial interview when you're being introduced, to say just a short visit, because otherwise they might be thinking, oh my goodness, how long is this going to go on for? And get tired. And
I anticipate that it will be people who maybe don't have many family visiting that will be wanting a visitor as well.
Yeah.
And for those people, they don't get to leave the ward very much. So what's coming to mind is perhaps using a wheelchair, maybe to have that conversation. We have lovely gardens around here, just to make it very informal and to sit outside and for it to be a change of scenery.
When I had visitors and we just went down and had a cup of coffee, it's still there in the coffee shop. That was the gardens. We'd go down there and even sometimes, I'm not saying we would do this, but they played fish, you know the game fish, because of my memory, and with friends, or we'd have a cup of coffee and play fish, and that just chatting over. We didn't play forever, but just chatting over that card game was a good visit. That's a good visit, but that probably may come later when the patient's a little bit more relaxed, maybe.
Exactly.
But
you can
that's,
introduce that. Why
yeah, that is a really good idea, because it gets them out of the ward, and it's lovely. It's refreshing. Yeah.
I was very lucky. I spent 4 hours a day. Just so when I left the hospital, they say, well, that's the first patient I've seen in OPH leaving the hospital with a suntan.
You were very fortunate.
If you didn't feel comfortable wheeling the person, we could get the PSA to wheel the person down. Physically.
Yes, because I don't think I'll be confident enough to wheel the person.
Exactly. So we would get a nurse or an orderly to do that.
Okay.
If that's what the person would like to do.
Yes.
There will be people who you might find not only talk, but they want to go on talking. I had big times when for half an hour, and I'd heard their life story right back to and you get quite exhausted trying to...
So what would you do? How do you...
Too much information.
Without being rude.
Occasionally I say, look, it's a very interesting story you've told me. I do have 4 other people on my list, so I better keep moving, I suppose. Because we get a list sometimes up to 9 or 10 people, and 10 minutes each time is probably sufficient to make contact with them and so on. And the other thing about it too, of course it's different here, is that you've got people in on quite a long-term basis. As I say, that I hardly ever see a person from one week to the next, but you see them on a Tuesday or a Thursday, and you go back on a Tuesday or a Thursday, and they're no longer there. They've gone home, and so on. And we've had occasions where somebody has rung and said, in this particular case, my wife is very anxious because she's going into hospital for heart surgery. Would you be prepared to come and talk to her about it? And when I got there, I found it was the husband who had the most anxiety, because who was going to cook the meals while his wife was in hospital? But I did follow it up to a extent. I found that she was being operated on, and I did see her while she was in hospital. It all went well. But that's a different situation again.
And I think visiting in the hospital, you'll feel supported by the team that's around you.
Like to go to somebody's home.
Because going to someone's home involves risks as well. So
or even phone calls, we couldn't monitor someone maybe phoning you at midnight or something, which is not appropriate.
harassing you,
It would be
But we wouldn't be giving them out.
no personal information about you. And we would sort of encourage you not to give your addresses or
No.
numbers
Phone numbers.
either.
Yes. Mm.
Yeah. Because it's always a
Like the same as staff members would never give out personal
No.
numbers
Yes.
or personal address, so it's same kind of.
But if the patient is very, 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 very happy talking to you, interacting with you, you leave them very, very happy. They might say, "Would you like to come and see me again?" You might, even get an invitation. If you have established a kind of a good relationship, you leave the person happy, because it's my policy. Every time I meet someone, I like to leave that person happy and wanting to see me again.
Yeah. And that probably is something that will come up quite frequently.
Yes.
So that's what we want to equip you with
Yes.
in this training in terms of boundaries and and how to respond to that as well.
The real issue is that having, in a sense, got to speak to a person, how do you, in a sense, almost not control the conversation, but how do you give them the opportunity to actually express where they're at? And that's why it comes back to the question of how do you encourage someone to open up to you and talk about, because we know that being able to talk about something is therapeutic in itself rather than keeping it buried. But how do you do that? How do you encourage a person? One of the techniques I've used, and again it's hard to make the transition, that having introduced myself and having indicated that I've had heart problems myself, I think I remember the next question I ask is, what have they got you in here for? Yeah, what do you got in here for? And they'll go on and say things like, well, I'm not sure yet, I've got to have another test before they finally decide, but it seems to me it's probably I'm going to have stents put in. That's one possibility. The other possibility is that I think my aorta valve is pretty wonky and they'll probably have to either replace it or repair it. In the case of them that have already been down the process, the next thing that they'll say is that, well, I've had a valve replacement and I'm a bit cross because I've got to take warfarin or something like that. And they're setting the agenda. But all I'm doing is giving them the opportunity to tell me what is their agenda. What is it that they're concerned about? What is it that worries them most, and so on? And in some cases, it's relatively easy to move it on. I mean, people say to me, I don't like this business of having a pacemaker put in. Is it a big operation? And I say, well, about 10 minutes. That's all it takes. And once you've got it, you're really in good condition. You're being safeguarded by having it. So don't get too stressed about it and so on. But anyhow, that's my experience. See, that I can say that the best thing that happened to me was have a pacemaker put in. But however, it gives them the chance to say, well, for example, see if I can translate that into your situation. A person's had a stroke and they say, the thing that worries me most of all is that my eyesight has been adversely affected by this. Or I'm finding it very, very hard to maintain a conversation because the connection between my brain and my mouth is not all that clever, or something like that. That might incidentally give you a feeling, well, I better not push it too hard.
Yeah.
Because you're really putting them under stress to do that. Can you think of other situations of a particular outcome of a stroke which you need to be very careful about? Is it hearing? Is it speech? Is it sight?
speech incontinence.
Yeah,
Incontinence?
So many things can happen as a result of a stroke.
Eyesight,
Yeah, coordination, thinking, planning, altered sensation.
Dignity.
That's a big one.
Mood, depression as well. There are lots of things that I guess they may say, look, this is something that we're concerned about. And I guess just going on, we're talking about, in terms of developing rapport with someone, which is really, what it's about. You probably have that skill in day-to-day life anyway, in terms of doing it in a semi-professional capacity is, just simple things like making sure your head is at the same level as theirs, maintaining eye contact. I think something like 90% of communication is non-verbal, so it's not what we say, it's our body. So mirroring their body language, if they're leaning forward, lean forward as well. If they're back, and it just makes that person feel comfortable. So just being, very open, rather than maybe sitting like that, just being open.
I know.
So just using those kind of techniques, I guess, in terms of developing rapport with the person initially. And it is, and once you have that rapport, then the person, it's about developing and gaining trust, and they will feel comfortable with you.
That's very important, the body language. It's also very important, I think, not to make an assumption that your experience is in any way similar to the other person. And that is a bit of a problem when you say that I've had a stroke and I've survived. Your experience of having a stroke might be so totally different to the other person that you've got to give them a chance to explain what the differences is. One of the difficulties with any conversation is to make assumptions. The old saying, if you make an assumption, you make an ass out of you and me. You've probably heard that before. Just using the letters of the word assumption you make an ass out of you and me. But so many assumptions we can make about things, and they're not always very accurate. And what anything else coming up out of this? That we've got to the point of what does the conversation involve, and we've got to the point of, let's say that the person is now asking you questions about, you've said to them, and I've had this experience and so on, and they want to know what it's like, right? How much time do you use up telling them all about it? Or is it wise not to say more than you absolutely need to? The point to be careful is, let's say, for example, that as a visitor you had found that it took you a long while how to walk properly, and that now that you're able to walk properly, for you see that a great bonus. I suppose it's possible the person to say, well, that's all right, I can walk, but I can't see. You see, in other words, it may be helpful if they've got the same set of problems as you've got. If it may not be helpful if your experience is being totally different to theirs. And so you have to, in a sense, sort of say to yourself, well, look, I better be careful that I don't imply that because I was able to walk properly again, you ought to be able to see properly again.
The first thing that comes very fast is walking, but I had serious problem with my left arm. So there are areas of rehab that are take much longer.
Well, let me put it more directly, and that is that the more you can encourage the person to talk and to tell you where they're at, what has happened to them, and what their fears or their anxieties or concerns are, the more you're in a position to understand them and to be able to relate to them as a person who, not as a person who's had all of those experiences, but as a person who has had the experience of being limited in some way by having had a stroke. The response might be that, what you've told me, I can really understand how difficult it is for you, because you mentioned, a little while ago, you mentioned that you love reading, but now it's very difficult for you to read. I think what I'm really saying is be very careful that you do not dominate the conversation. Even if there's silences, don't sort of rush in and fill silences. Give the person they may be just thinking very slowly about things, right? And be very careful, as I say, not to dominate the thing.
And I think in my experience too, if you can just, as uncomfortable as it is, if you can just sit with the silence with someone, that's when you get the best out of them, the most sort of revelation or expression or, you know, a really heartfelt comment if you can. So it's difficult to do, to sit with the silence.
It is actually, it is difficult.
But really
but
worthwhile.
You know, you're there to listen, so if you can just quiet them down and listen to their story.
You know, I have come across, say, 3 friends who have survived stroke, and they heard about it, they heard about me. When I saw them, you know, it's just so natural, you know. We started talking and she would be asking me, what happened to you? And then, you know, and that's how the whole conversation started, about what happened, about the medication, about the support that I had, the physio, the occupational therapy. So, you know, it's just like another person who has had the experience, and the conversation just flowed very, very naturally. So I'm just thinking, you know, I know it's different because the patient has got a different type of stroke maybe, but you know, that's what happened to me when I meet my friends who survived stroke. They bombarded me with so many questions, and they wanted to tell me what happened to them and how they could help me, for example. And from what I said to them, they said, oh yes, I think I'm going to do that too, you know. So I know it's not relevant, but I'm just thinking that, you know, a survivor to another survivor, you know, how they compare and then encourage each other.
And that's, I don't know if you've ever been to any of the National Stroke Foundation peer support groups. They're held monthly here, and that's exactly what they're about. That's where people come together and share their experiences and talk about what's happened. So that's a really good forum. That might be something you might be interested in going to.
Because you can learn. You can
people
learn
do
from
have
that.
a need to share what they have been through.
I think it's a great idea to do that because people learn from one another, and they learn to understand each other and so on.